Welcome to this week's episode of UT Ortho's Game Ready series. I'm Dr. Bonnie Gregory. I'm here with my brother, Dr. James Gregory.
Older brother,
has to be noted, to talk about shoulder injuries in our athletes. So welcome. Thanks for joining us.
I'm very honored, and I'm impressed you're able to score such a high-profile guest like myself.
Fun fact, we've never done this before. But
We're just going to be spitfiring here today, so no promises. If this ends up amazing, it could just all crash and burn, and we start, poking fun at each other, which would be equally entertaining.
Absolutely.
Right?
So the sibling shoulder rodeo is what we'll call this now. Anyway, we're gonna talk about some kind of the shoulder in the athlete, both the throwing athlete and the contact athlete, from our two perspectives. So I'm a sports surgeon, and the other Dr. Gregory, which we all call him, is a shoulder and elbow surgeon. So we'll kind of try and cover some topics from both of our perspectives.
Yeah, and so I think probably the easiest way is just kind of, ask questions back and forth.
Yep.
And, one of the things that, I find really interesting, I see a lot of shoulder or elbow problems from a lot of different things, but taking care of a lot of athletes and on-field management of stuff, what's probably the most common shoulder injury that you see in your athletes?
Yeah, absolutely. So especially with fall coming up and football season right around the corner, there's lots of kind of game time decisions that happen for our players and seeing who we can get back out there during the game or who needs a little bit more acute management. So some of the most common things we see, especially in football players, and some of these may not even make it to you, are AC separation, so acromioclavicular joint separation. So hopefully we'll get a little slide to push in here with the anatomy, but especially in our running backs, wide receivers, anybody who's kind of getting tackled from the side of the shoulder or into the ground, they can get various degrees of a sprain of the top shoulder joint, the end of the collarbone where it connects to the rest of the shoulder girdle.
And so where is your AC joint for everybody if you had to show them?
Yeah, so especially if you've played sports before, you may have a little bit of a prominent AC joint on the top and side of the shoulder here. It tends to be an area that in older patients gets a little bit of arthritis, but in younger patients is more prone to getting injured. A lot of the times these athletes will actually be able to finish whatever play they're in, and then they'll come off the side of the field and be doing one of these, hey, yeah, it doesn't feel great. Thankfully at all of our partner schools, we have awesome athletic trainers. So they're generally going to do the initial eval, make sure they don't see any signs of a clavicle fracture or collarbone fracture, and then getting over to the AC joint, testing range of motion to make sure, of course, if someone has full range of motion, full strength, just a little soreness, that tends to be less severe of an AC joint injury, and we tend to be able to let them get back in the game if they're comfortable. Those that are more severe or even have a step off, if the collarbone is elevated up and it's visibly different from the other side, or if they've lost any of their range of motion or strength, I tend to pull them out of the game for more evaluation.
Do you get x-rays on those people at the time of the game, or do you kind of have them follow up with somebody to get x-rays afterwards?
Absolutely. It totally depends on the level of injury and level of play. For our high school athletes, assuming that they're comfortable enough at that moment, I will pull them out of the game, but we will get x-rays either that night or that weekend in urgent care or follow up in my clinic, depending on how severe it seems, just to kind of check the degree to which it's been injured and then give us a better sense of how long they may need to be out.
Yeah.
How about you? You see AC injuries in clinic, but I think yours tend to be a little bit more chronic.
I do, yeah. So if they make it to me, they're the bad ones, because someone comes in and, they can tell. They're like, hey, doc said my shoulder separated, or they've been seen in an urgent care and they've been told they have a shoulder dislocation, which is not typically what we refer to as a shoulder dislocation. That's something different that we'll get into. But they'll come in and say, hey, like my shoulder looks low or my collarbone looks high. And basically, as Dr. B. Gregory was telling you, that's because as you kind of land on the shoulder, you tear ligaments in the front and you tear ligaments on top. And that pulls your whole shoulder down like that. So the classic one's like a quarterback getting tackled and wrapped up and kind of landed on the shoulder. And so when we see people that have those bad shoulder separations or AC separations, we get x-rays if they haven't had them already, and then we have a conversation. And a lot of the times the conversations is, do we need to treat it surgically or do we need to leave it alone? And it's a lot about how bad it is, what the patient or athlete wants to do in terms of getting back to sport, because leaving it alone means you'll be able to get back to sport more quickly. But the problem is it's going to stay how it is. And so, if you don't like having a shoulder that's drooped down or sticking up, or if it's really far off, then sometimes we may need to fix it. That slows things down and will probably put people out for basically the season. And so generally we won't do that with in-season athletes. We'll consider it sometimes off-season. And in people that are non-athletes, sometimes people want to go ahead and get it fixed right away. But there's a little bit of a kind of a discussion because it's not one size fits all.
Absolutely. You brought up an interesting point, and I think it may also be a differentiating factor for how these injuries go, how long you're out, is the position you play. If it's a quarterback and it's your throwing shoulder, that's very different than a lineman or a running back who may not be using that arm in an overhead fashion. So have you noticed that the ones that come to you are more quarterbacks? I would say the ones that I see are more kind of the linebackers, running backs, because they can get back out with kind of without needing that overhead.
Yeah, the ones that, and because that's one of the things, and this gets a little more into the weeds, but if you think about it, if your shoulder's kind of dropped down like that, all the orientation of your muscles and how your shoulder works is a little bit different. And we like to, we both do a lot of research and we're really interested in how the shoulder works. And there's not a lot of research on how that affects your shoulder long term. Because what happens is your shoulder will kind of roll forward like this. And so, yeah, maybe you're kind of doing everything. But if you're an elite athlete or you're someone who really needs high velocity or needs a lot of stuff over your head, that may make your shoulder fatigue more quickly and it may set you up for bigger problems down the road. And so one of the things that we're doing here at UT is we're actually taking all these people with these AC joint injuries and we're doing research into how the shoulder moves after injury, those who we treated without surgery and those who we treated with surgery, to try and kind of understand some of these problems so we can help talk to athletes and patients better, saying, hey, you're a quarterback, you're a baseball player, you're a volleyball player, you're someone who needs to do a lot of overhead stuff. Maybe this is something we're going to be a little bit more aggressive on just for long term. Or you know what, you're a hockey player, you're playing with your stick down here. All those hockey players in Houston, right? That's something that, we can kind of just leave it alone.
Yeah, I think that's a good segue for another one of the on-field injuries that I see a lot is a clavicle fracture.
Yeah.
So super common, especially in our contact athletes. And I think the management of it kind of depends not only on the age of the patient, of course, degree of injury, but also the sport that they play and what position they play. So when I see them on field, any broken bone is basically going to get taken off the field, especially at a high school level, which is, what we need to do to prevent any other secondary injuries from happening. And then either I'm going to see them in clinic, or if they're somewhere else, they're going to potentially come to your clinic. So how are you making those decisions on who's getting fixed, who's not? How long are you telling, it's week 1 of the season. How long are you going to tell that starting quarterback that he's out, if you fix it or if you don't?
That's a really good question. And I think, you brought up, I've got it easy because they come and I can get x-rays right away. You've got the hard job because you come out, they come see you, they're like, hey, I'm hurting. And you don't have the benefit of x-ray right there being like, hey, it's broken, XYZ, here's what we do. And so before we get into how to fix it, how do you know without x-ray that it's broken?
Great question. So a lot, similar things that we're doing for the AC joint. So examining the area. So broken bones will have a feeling to them. It's called crepitus, and all of our athletic trainers who are hopefully tuning in will know this, but it's a sensation of that bone being broken underneath the skin. It feels like there's a break in it. And oftentimes the athlete will say, hey, I felt a pop, I felt a crack. Something like that. I'm going to examine the actual bone itself, palpate or touch for any differences in that bone. And then same thing, occasionally we do some vibratory sensations, stuff like that, to see if it if the athlete has a lot of increased pain at that site for those same things, because we don't have the benefit of x-ray.
Yeah.
And we can make a little of those, early decisions based on that.
And so, so getting back to your earlier question, you mentioned kind of how do we manage people with broken collarbones or clavicles? And first thing is we look at how far the clavicle is displaced, which means basically shifted apart. And so if you think about your collarbone, it's essentially a straight bone. And so when you come in, if it's basically straight still, then fixing it's not really going to do much because it's already straight. We don't need to make it straight, so we can leave it alone. If it's what we call displaced, or if the bone ends are apart, then that's something we'll be a little bit more aggressive with, because it's harder for the body to heal the farther apart the bone ends are. And so that's something we may be more aggressive about fixing. If we fix it, what that means is we basically line the bones up straight. We use plates and screws to kind of put those back together. So that's a surgery. The good thing, this is different from the AC joint. So AC joint, we talked about, you're quicker to get back to sports if we don't do surgery. collarbone fractures or clavicle fractures are quicker to get back to sports if we do surgery. Because if you think about it, we're putting all this really strong metal and screws in there. And so when we put the plates and screws on there, it's nice and strong. So I usually let people go back at around 6 weeks, as long as they're feeling good. If we have the time, I'll stretch it out longer. By 3 months, everybody's fine. But usually 6 weeks, I'm okay with it. How about you? How long do you wait?
Ditto. And I would say if in some of the younger athletes who have open growth plates, we tend to be a lot less aggressive because they tend to mend themselves a little bit better. But in those athletes, we have to keep them out 8, 10, even 12 weeks, depending on how the bone is healing. So as Dr. J. Gregory was saying, fixing these, especially in our contact athletes, can get people back a lot sooner.
Yeah. So we talked about, different parts of the clavicle, AC joint, collarbone fractures. What other things? Do you see a lot of people with shoulder dislocations?
I would say not a lot, but more commonly we see things like stingers on field. So some of the times we have athletes who have had dislocations in the past or have had what's called subluxation, where the joint almost slips in and slips back into place. That can be thought of to feel like a stinger for athletes, or if I got hit or my arm got pulled and it feels like my arm went numb. In those athletes, I'm checking 2 things right away on the sideline. One, I'm making sure their neck is okay, because it can also be kind of a cervical or a neck issue, or kind of the nerves in between the neck and the shoulder issue. And then if I have them on the sideline, I know that they're one of my subluxators or dislocators, and I'm checking their range of motion, their strength right away. Occasionally, I would say at least once a year, every football season, even soccer seasons, I've had some onside shoulder dislocations, and thankfully when I'm there I can put it back in place, and many of our athletic trainers are trained to do that as well. But I would say at least once a season I get a shoulder dislocation on field.
Yeah. And how do you decide, with the people that dislocate your shoulder, are you ever letting them go back at that same?
I don't that same day, especially if they're a first time injury, because I don't know if they've also broken a bone. And that's a big thing that without, like we were talking about earlier, without x-ray on the field, there's no way for me to know if you've chipped a little piece of that socket off when the ball came out of place. Those kind of subluxations or the stingers are a little bit different. If someone has one of those, they still have full strength, full motion, and it resolves very quickly, and they're not having any residual numbness, tingling, anything like that. I will consider letting them back after a period of time of rest and kind of rechecking their strength as we go.
That's great. And so after you see, so the person who did come out and they dislocated their shoulder on the field, when are you seeing them? Are you getting MRIs on everybody? How do you manage them, and when do you let them kind of return to play?
Yeah, absolutely. And this is a big benefit. And if you guys take nothing home from this, if someone's dislocating on the field, or if you have dislocated or your child is dislocated on the field, get them to a shoulder specialist, and as soon as possible. The old dogma of the shoulder comes out, it goes back in, we play the rest of the season, deal with it at the end, which has some role for some certain things, but not until we've evaluated it. So I get them into my clinic that week, get some x-rays to start with, and then potentially an MRI as well in season. Also kind of depends on what their symptoms are then. If it's their first time, where we are in the season. What about you? I know these probably roll through your door all times of year, but say it's, we're 2 weeks from Texas high school playoffs, and you get a player who comes in dislocated last weekend.
So basically I have a similar kind of approach to you do. And so my general thought process about when I let people play are, are they safe? Can they protect themselves, and are they going to do more damage? Mm-hmm. And those are the things that I think about in my mind. And so if someone comes in, they're like, hey doc, I dislocated my shoulder in a game like last week. You know what? I feel pretty good, a little sore, but it's not bad. Then basically once they, as you were doing on the field, once they have full range of motion, full strength, they've got a couple weeks left of the season, playoff time, I'll let them go back. The caveat is, I say, your shoulder, each time it pops out of socket, it damages some tissue within the shoulder. It could be the bumper of the shoulder, which we call the labrum. It could be some of the ligaments of the shoulder, or it could even be some of the muscles or the bone. And so each time it pops out, it makes it a little bit more likely. And so you're running a risk. I can say, hey, I'm going to let you go back, but be aware you're at a risk that your shoulder may come out again. So maybe depending on the position, we can put them in a special brace to kind of help protect them. But essentially, it's something that does have to get worked up at some point. So yeah, we can get you through the season, but we should get an MRI. We should see what the damage is, because what happens as that damage gets worse and worse and worse each time it comes out, fixing it gets harder and harder and harder. And it can take a really easy surgery, or really easy recovery and make it a really hard recovery. And so what I usually talk with athletes about, even if it's come out once, and say, it depends on your age, right? So if you're young, and you're an athlete and you've dislocated completely, it's going to be approximately 90% chance at some point in your life it's going to come back out again in the future. And so that doesn't mean this season. It may mean 2 seasons from now. It may mean next year. It may mean when you're 25. And so that's why it's important to work with a physical therapist and work with that. But it's also important to think about, maybe I want to do this on my schedule. So maybe I don't want this to happen during next season. Maybe I want to just go ahead and get this fixed in the off season, so that way I'm done and I don't have to worry about it. And so that's why it's important to kind of have a conversation with the specialist like Dr. B, Gregory, or myself, because you need to kind of have these conversations talking about age, what you want to do, how bad the damage is. Is there a piece of bone that's broken off? That makes it way worse. That means we generally need to fix it. And so there's a lot that goes into it. But in general, if someone's not going to do more damage, they've got good range of motion and good strength that they can protect themselves when they play, then I'll let them go back.
Cool. Any other injuries that you wish you had seen sooner? That you have a kid comes in and you wish that they would have come to see you during the season versus the way end of the year?
Yes, there's a couple things I'd say. So one is anything that you feel a pop and you have bruising and swelling. Any pop and bruising and swelling, you need to get checked out, because that's a sign that something's torn. And the worst things I see, and it's not just athletes, it can be like, someone at the gym working out, but they feel a pop, bruises, swelling. They're like, you know what, I'm going to keep an eye on it. They give it 6 weeks, and then by the time they get checked out, we figure out something's torn, and guess what? Now it may not be fixable, or now it's way harder to fix. And so anytime you feel a pop, bruising, swelling, go to a doctor, get checked out. Definitely. How about you? Anything?
Yeah, I would say that's similar kind of. I think he's alluding to pec ruptures and things like that. Not necessarily in our high school athlete, but for sure college and above, those are things that we don't want to miss. But I would say the same. Any pop, swelling, bruising, any total loss of motion in the shoulder joint at all that's not getting better, not any kind of huge change in someone's way they're throwing or their velocity, things like that, that should come in to see us too.
Exactly.
Kind of to pivot a little bit, and I know that we've already had some awesome talks in our Game Ready series about the shoulder already, but just to kind of highlight some of the other athletes that we see, those overhead, overuse athletes, what are some of your take-home points for kind of those athletes, their parents, their coaches? What kind of things do we need to be concerned about?
I think there's, the vast majority of things I see in overhead athletes are related to overuse, right? And it's because we're putting so much force across our shoulder and our elbow when we throw. And what happens is that can lead to injury over time. And there's a couple take-home points. One is that it's all a chain, right? So I'm just going to focus on throwing like baseball, because that's the most common thing I see, but it applies to volleyball and everything too, is, it starts with your core, your legs, and travels up, right? So the weakest part is our elbow, followed by our shoulder, and then everything else is strong. So when everything else fatigues, we put more stress on our shoulder, more stress on our elbow, and that's when we get injured. So for any thrower, don't neglect your core, don't neglect your legs. Other thing is you got to focus on flexibility, right? So when you throw, all the ligaments in the back of your shoulder get tight, because if you think about it, you're putting so much force through your arm's going to just fly off unless you have all the muscles and ligaments in the back to kind of slow things down. So as you throw, that gets tight, you start to lose some range of motion, and then you start to get injured, because as your range of motion diminishes, then you start to kind of cause other problems. And so biggest thing I see is, keep your core and legs strong, focus on shoulder flexibility. People who are pitchers or who throw a lot should be doing stretching exercises every time they throw. They should be doing stretching exercises on their off days. So last thing, listen to your pitch counts, follow all the rules, because that's going to help prevent things. How about you?
Totally the same. Also, I'll add in at least 2 months of rest a year, and consider some cross training and some kind of delaying sport specification as long as possible. As awesome as it is to be the best pitcher at age 12, it's even more awesome to play in the major leagues. So I think it's a lot of that management of load in the younger athletes, kind of teaching them how to engage their core and use the neuromuscular chain, not just for the upper extremity, but lower extremity as well. And then, for those of you guys who didn't catch it, Brian Duncan and Sean Kennedy, 2 of our awesome physical therapists who work with us at Ironman, did a great video a couple weeks ago on this page about some of those stretches and dynamic warm-up that you can tune into and get some other actual kind of techniques for how to do those with your athletes.
Yeah, I mean, bottom line, I mean, you got the Game Ready series has been such a great series with so many good tips for everybody. And in terms of anybody, you know, who's an overhead athlete, it's all about prevention, right? So doing all the stretches, doing all the kind of, you know, I mean, even from the nutrition standpoint, I mean, there's going to be a ton of stuff on this series that's going to really kind of help keep you guys. I mean, I love y'all, but it's even better if you don't have to come see me in the office because you're not getting hurt, right? So that's kind of the takeaway from all this.
Yeah.
But yeah, anything else you wanted to discuss today?
No, I was just going to say same thing. I love taking care of athletes. I love being on the sidelines, but my best games are ones when I'm not needed at all.
Exactly. Well, awesome. Well, thank you so much. Any issues, you know, reach out to us.
Yep.
Bonnie Gregory, James Gregory. We're here for you. Thank you, guys.
Thanks.